I'm going to start today talking about optimizing rTMS approaches based on individual resting state networks. And I am right. So I'm working at the University Medical Center Göttingen in Germany. And this is the page for our research group. And if you have any questions or want to know more information, you are welcome to go there. I will show a little piece of what we are doing in there. And I want to thank, of course, ANT Neuro for this possibility today, as well as disclosure, no relevant financial conflicts of interest. So one of the main questions I had, was, of course, what is the current situation in the treatment of unipolar depression, and if we could still improve treatment options, for instance, with navigated rTMS. And for that, we created a systems medicine approach with a project called PreNe, and I'm going to be talking about it in a minute. And I'm going to close up with a summary and, of course, QA session. So unipolar, very briefly, I hope most of you know this, but unipolar and bipolar depression, they are somehow different. And I hope you can see also my arrowing here.
Yes, we can see that.
Good. So we have certain range in which our emotion is changing a long time, and by depressive recurrent episodes, we can actually see that patients go into a much more extreme lows in their emotion. I'm going to be talking about symptoms in a minute. But differently, bipolar disorder goes actually to those same levels, as well as high levels, or mania, as we call in the psychiatry field. So treating them is still very difficult, and we still have somehow a limited therapy arsenal. So you can see here, this is a relatively fresh chart from World Health Organization showing that 322 million people is affected worldwide. So this is a very big problem nowadays. And it's being distributed among all this region. So there's no particular preference of where this is occurring. And the most puzzling part that most of the people do not know is that about a third of those that suffer from depression do not respond to conventional therapy. Conventional therapy is all the lists of medication that we've been developing, working on, and prescribing to patients along the years, as well as the different types of psychotherapy that exist out there. So actually, to have about a third that do not respond to those is a relatively big number, as you can see. In these cases, there's a lot of promise with some stimulation protocols, and in this case, also 2 of them have been approved by FDA. So rTMS has a lot of promise in this sense. And nowadays, we know that about half of those participants that end up having clinical application of rTMS, they do not respond. This is, of course, a question of, can we really improve that? The 2 protocols I mentioned are here. So these are different paradigms and of different pulses that are given a specific period of time. And 10 Hertz and ITBS are the 2 protocols that are generally being applied in the clinical treatment of depression. So you can see here an interesting part already, that this initial one that was accepted by FDA about more than 10 years ago takes about 40 minutes, and a newer protocol takes about 10 or even 3 minutes sometimes. So it's actually way more convenient for patients. But what is really the putative mechanism? So not really understands, but we know that stimulating the left dorsolateral prefrontal cortex, this region you see here in lila, actually alleviate the symptoms of many patients. We know from imaging the brain more and more, particularly with functional magnetic resonance imaging, fMRI, which allows us to give and to have a very good spatial resolution in vivo in the patients. We understand from patients and also from healthy volunteers more and more how those systems are more or less related to different, so the circuits are related to different symptoms that are shown by depression. So you can have some psychomotor as well as cognitive, emotional, and neurovegetative symptoms. They are also enormously variable in patients, so not all the patients present a similar combination of those symptoms, which makes, of course, a bit more complicated in terms of deciding how to treat each person. And up to date, more or less, of course, we know from the clinical part that you can have higher chances of somebody probably benefiting for a certain medication or psychotherapy treatment according to this combination of symptoms, but quite really in a trial and error way. And it's actually not really biologically rooted yet. This will be very, very useful if we actually move into this. I want to call attention to the specific region here. So here you see the subiculum, and right below it is the subgenual, the genu of the corpus callosum, not subiculum at all. I was thinking about something else. So the genu of the corpus callosum, and right below it is the subgenual ACC. So it's actually a specific region in the brain, related specific particular region in the anterior cingulate cortex, have been consistently shown more and more in depression to be associated with response to medication, also ECT, so electroconvulsive therapy, cognitive behavioral therapy, as well as even set memories. So this has been shown repetitively in the literature and suggested to be perhaps a biomarker of the symptoms and also therapy response. So how severe that is. In fact, this is a region have encouraged placing a probe, an electrode for deep brain stimulation, as you can see here, in very, very extreme cases. And matter of fact, there's been a huge advance in this situation, because we clearly can see an association of a specific region in the brain to this symptomatology that is manifested in depression. We don't want to go there, of course. We don't want to have such an invasive procedure done in all patients. So transcranial magnetic stimulation is, of course, from the non-invasive approach, a fantastic possibility. And it is known from today, this is a consensus, that it has level A recommendation, so it's definitive efficacy on the left dorsolateral prefrontal cortex. And also another evidence is this known inferiority of ITBS versus high frequency rTMS, which is, as I mentioned in the beginning, also a shorter protocol and is very convenient from clinical use. All right, so we come to the first interactive action session. Are you guiding this, Furnash? Yeah.
Okay, let's give this 30 seconds or so. Functional MRI is a method often used in clinical research because The poll is ongoing. Okay, around 50% of the participants voted. We hope for more attendance. There it is. So I close the poll and we share the results. It seems that the second option, it offers excellent spatial resolution, has the highest vote, 72%. And then the first one, 17%. Well, who knows, 11%. Is that what you expected, Roberto?
Yes, this is exactly what I expected, so that majority would know that the spatial resolution is the main characteristic of fMRI that allows us to really make good use of that in the clinical part. It does not require exogenous contrast substances, so it is relying on the our physiological perfusion contrasts in there. That's how we basically measure and set that. And I like also that some people reply to, well, who knows? So this is a very interesting, quick overlook on basically how we have the participant laying down in the scanner. And we can, as I said, actually measure according to the amount of perfusion right after activation of certain regions in the brain. We can estimate from this coupling from perfusion and activation exactly structures that are being activated indirectly. And what I wanted to show here briefly is more interestingly, in the last years, we developed a new ways of approaching this information, and it goes into the functional networks. Differently from activation or deactivation in the brain, we can actually trace in time which regions preferentially connect to each other. So which regions have been active and deactive in a certain space of time. That could be evaluated also in resting state, which means an absence of a specific task. And in certain cases, very, very useful for patients because then you don't have different limitations such as cognitive deficits playing a role in their ability to perform certain paradigms or tasks. To evaluate activation, you can have them basically laying down there with such instructions as please allow your mind to wander, keep your eyes open, do not fall asleep, and we monitor through their eyes that this is really happening. So here you can see that the brain modularly would be organized with some examples of networks in there, and more we understand that such combination of structures of regions in the brain are responsible on doing different activities and allowing us to dynamically achieve and change our resources very quickly and do a really good job in performing our day-to-day and also flexibilizing our resources. I want to call your attention to the default mode because that has been a network frequently associated to symptoms in depression. I'm going to come very briefly with this slide to this point. So here you can see some medial prefrontal regions as well as the posterior cingulate cortex. And these are very, very strong nodes, important nodes of the default mode network. Actually, you can see as well how close that is for that region that I was talking before, the subgenual ACC. And interesting, this is a very classic image that's being shown more and more. the default mode network, which is a regions that are generally more active when someone is not engaging in a specific task, are anti-correlated to those other regions in blue in here that are regions that are more activated when we are engaged in specific tasks or really interacting directly with the external world. You can see here the warm colors and the cold colors in the graph in time, and see how basically anti-correlated they look. Why am I talking about this? Because there's been also in the literature a suggestion that if we are going to stimulate this blue region, the one I just showed before in here in the dorsolateral prefrontal cortex, that would be part of this blue network, so the task positive network, it has been retrospectively seen that patients respond best if this specific region where the stimulation was taking place is actually anti-correlated with to the subgenal ACC. And this could actually be a hint in terms of optimizing, a possibility of optimizing where we're going to perform the stimulation, perhaps having more and more people profiting from such an intervention, which has been actually not done until today. And this is a also very interesting study that shows how we take, for instance, the separation of this different modular organization of networks in a group level as well as the individual level. And here you can see, for instance, how much more precise fine-grained differences exist in the individual level. So if we do not take the individual level into consideration, we might actually be losing the possibility of changing really the symptoms of a patient. That was basically what we had in mind. So we come to the second question in the interactive session. Should I read it?
Yes, please. What characterizes systems medicine? It seems that the word is missing there. It focuses on the investigation of mechanistic processes. It does not aim to improve responses to treatment. Well, who knows?
Yeah, so here is also the correct response, and it in fact does aim to improve responses to treatment. So these are two major characteristics of systems medicine, and I still like the fact that some people reply to, well, who knows? Moving forward, systems medicine here, I want to briefly show what was the concept. We wanted to image experimental interventions to actually based on a model of a certain disorder, in this case, how depression and networks are related and has been shown before in other studies. And the idea of imaging that would allow us to model a system that involves also more complex and refined data, hopefully including then omics data, multi-omics data, as well as phenotypic data. And with that, we could move towards a better comprehension in also the personalized clinical application that would also increase the comprehension of this model of the disorder. And in this case, we then built this big study called PreNe, PreNest is an acronym of Pre-Mapping Networks for Brain Stimulation. It comes actually, it's a Czech word, I didn't know that in the beginning. It means actually to transfer. It fits really nicely to this. The aim of it is to tailor optimal rTMS protocol based on the individual resting state networks. And it comes divided into spheres, so basic and translational. I wouldn't achieve that with a fantastic team. So these guys here have been those that most contributed to the study until now, and I'm very grateful to their help on it. The basic sphere consists of pre-mapping networks, and then it moves to a session in healthy volunteers, only one session, using a method that we developed in the lab to personalize such a decision where stimulation is going to be given. And then we measure its effects in a very tight way, as I'm going to show in a minute. The idea is actually to develop this method of target selection in an individualized way, and also measure the brain and potential behavioral effects on it. So participants will come to us. They're going to have a big battery of scales, and we're going to collect all possible demographic as well as clinical data. They will go into the scanner, and we have structural as well as resting state measurements in there. And then we're going to calculate specific networks for each participant. I am not getting my cursor. I'm sorry. I'll try to.
Roberto, you want to play the video? Oh, you see it back.
Yeah,
great.
Do you see it? Right. Okay. So the point is, you have the possibility of deciding anatomically where the dorsolateral prefrontal cortex is, but for each participant, you can also see where the overlap of those networks also is, the networks that I'm going to explain in a minute. And then this can be played into the neuronavigation system as general is. And this is something that we're going to have, I guess, a demonstration right after. So I'm not going to go into too many details in here. What I want you all to see is basically how do we come to the decision of doing this stimulation for each person where. And of course, after the intervention, participants will go back to the scanner. We will measure as fast as possible right after the stimulation what are the changes that we see in terms of networks in there, and they go again to this battery of a clinical assessment, and to see if any differences might perhaps be evidenced, which we didn't really expect from one single session in healthy volunteers. So here's a very quick description of a very complex study design. They are basically 3 days, day 1, 2, and 3. You have this for the first resting state data that we collect. We calculate the target selection for each participant, and then we apply either sham or real in a crossover design, considering a baseline and 3 resting state scans, that because we want to evaluate as well what are the changes that are happening in time. So I'm not going to go into many details in here, but just for you to understand that we do use a lot of the standard pre-processing pipelines of generally should be taking place, and then in SPM, and then we move to a specific segregation through independent component analysis to components of our interest. In here we have the default mode, and in here we have the frontoparietal network, so the 2 networks of our interest, and to understand best what is the interaction between them, we invert the resting state network from default mode, and we see from this inversion mathematically which parts of it are actually touching the parts of the frontoparietal network. And then we see from this overlap what is the strongest node in there and how we should really, in an individual way, apply stimulation. So this I can pass through. So here will be 50 people with stimulated. And here you see in the start where the typical default point is based on the anatomical decision of the default mode of the dorsolateral prefrontal cortex. But here you see how variable those points were when they actually strongest related to the subgenal ACC. And so that is the picture I wanted to show, how variable that this can be if we really base this decision on individual resting state network. And what did we find? We found that the DMN actually, after 30 minutes of applying the 10 Hertz protocol, decouples from the specific region, which was exactly the region we wanted to tackle. And because this is a region that has been shown in patients that have been hyperactive, and we basically disconnected this region through one session of 10 Hertz rTMS in healthy volunteers, extending as well to other interesting regions that also been shown to be related to depression, such as the ventral striatum, here closely the nucleus accumbens. Also, we found that there are differences between 10 Hertz and ITBS. So in this modulation of the default mode network, here are two different cohorts of healthy volunteers, and the first data already, in the first line, I already described to you. ITBS, we did not see actually a subgenual, but actually more a pregenual going to the dorsal anterior cingulate that ended up expanding after 45 minutes to more in direction of other frontal areas of the middle prefrontal cortex. And interesting wise, also a decoupling of the insula, which is a very another important region in this disorder, implicated in the disorder. What we found interesting in here, and we ended up replicating in different perspectives. So you could see here that the alterations that we have in the network do not show one-to-one in time, nor in terms of type of protocol we used. So that gives us hint that they actually acting through a decoupling of different structures and different networks in one single session. And we turned out seeing that actually these effects relate to a specific measurement of personality scores. So there's a certain domain in this personality scores called harm avoidance, and we could actually see that the effect for this connectivity is happening stronger in those participants who actually had a lower level of harm avoidance if with 10 Hertz, but if with ITBS, they were actually happening in the opposite way. And this relationship did not show true in sham. So we come to the third and last question from the interactive session. So can we assume that the same effects seen in healthy individuals will occur in patients with depression? The options are yes, of course. Second is no way. And the third is, well, who knows?
All right, here are the results. Well, who knows?
Yeah, this is more or less
That's
what
a
we.
tough one.
Yeah, that's more or less what we think. There's no guarantees that will be really happening, so nobody actually knows if it will be the case. I'm so sorry that I'm actually having some trouble with the technology here, but I can either close my window and see my slides, or
Maybe you can close and to start again with your slides.
should I
You can
close
see
my
your
window?
mouse.
Yeah.
Yes,
Now
there
I
it
see
is.
it. All right. Okay, so as you remember, this is the basic sphere of PreNe, and in which we had one session of personalized stimulation, and we wanted to see what was the difference between the baseline and after stimulation. And now we come to the translational sphere, which in fact we're going to be evaluating really patients with depression. This is an ongoing phase now in which we are actually testing if individualized target selection would really make or not a difference clinically in comparison to an F3 stimulation, which is happening after the stock in the practical session, as I heard. So basically, nowadays in the clinic, this is a possibility and very easy to happen, but perhaps some patients do not benefit from a simple F3 stimulation, because the strongest spot where they should indeed be stimulated might be actually not spatially very close to it. And that's basically what we are testing right now. So patients go through 5 times of weeks to stimulations, and basically we see the follow-up scans, what are the differences that we see, if they actually correlate correctly as we expect or not with clinical differences. We have also collection of the omics, multi-omics data and phenotypic data. We bring from the previous phase the method that we, of course, developed with healthy volunteers for individualizing this target. And of course, we evaluate again all the battery of brain and behavioral effects. We, of course, do not do that ourselves, but we have also collaborators which are going to be covering the part of the multi-omics. And the exact same approach will be then done in patients. So to sum up, what I show you today is that there is evidence supporting rTMS as a possible personalized treatment in psychiatry. What has been our experience with the PreNe study in the basic sphere and now the ongoing translational sphere, and the fact that with systems medicine approach, we can actually have a possible mechanistic framework that will be very, very helpful in a new phase of hopefully personalized medicine or systems medicine. So I thank you very much for your attention. Thank you to for those that have holiday today in a sunny, beautiful day and actually staying here. And I thank, of course, all the funding agencies. Thank you so much.